I'm Dr. Jim Simon, clinical professor at George Washington University in Washington, D.C. And it's my pleasure to moderate this webinar for IMS titled Sexual Health Issues in Menopause. This webinar was supported by an unrestricted educational grant from Bessans Healthcare. Bessans Healthcare had no role in the selection of topics, selection of speakers, and have not vetted or reviewed the content of the speakers' presentations. Today, I'm joined by Professor Margaret Cruickshank and Dr. Nneka Nwokolo in their presentations. I would like to introduce them to you now and thank Dr. Cruickshank for handling the Q&A following the two formal presentations. Our first speaker is Professor Margaret Cruickshank, whose title is HPV and the Menopause. Professor Cruickshank is a clinical academic at the University of Aberdeen. She co-leads the Aberdeen Center for Women's Health Research. She's a past president of the BSCCP and president-elect of the European Federation of Colposcopy. Her program of research focuses on pre-invasive disease of the lower genital tract. She's lead for the NHS Grampian Colposcopy Service and provides a tertiary specialist service in lower genital tract disorders involving vulvoscopy and high-resolution anoscopy. Our second speaker, Dr. Nneka Nwokolo, will speak on sexually transmitted diseases in older women. Dr. Nwokolo is Senior Global Medical Director at ViiV Healthcare and an honorary consultant physician in sexual health and HIV medicine at Chelsea and Westminster Hospital in London. Nneka is passionate about sexual and reproductive health in women living with HIV, particularly regarding contraception and the menopause. She was the lead author of the current British Association for Sexual Health and HIV National Chlamydia Treatment Guideline, and she's the author of many peer-reviewed scientific articles and book chapters. So without further ado, I'd like to introduce Dr. Cruickshank and her presentation, HPV and the Menopause. Thank you very much.
Thank you very much, Professor Simon, and thank you very much for inviting me to talk today. And often when we're thinking about human papillomavirus infections, we're thinking about younger women, but there's a lot of important messages around women in the post-menopause. So in the UK, there was a big media alert just in the last couple of weeks about could women have a single smear test in a lifetime. And that was in relation to young women who have been offered the HPV vaccine, where we've seen in the UK with high uptake of HPV vaccination, a 90% reduction in precancer of the cervix and an 89% reduction in cervical cancers. But that leaves the unvaccinated women, and particularly older women, and as I'm going to explain, there's particular concerns around HPV, precancer and cancer in older women. So it's very clear that cervical screening needs well organized screening as a public health policy with organized call recall. And part of that has been around the limitations of cervical cytology, that it needs to be repeated on a regular basis. In the United Kingdom, where we've had 3 yearly cervical smear tests, it means in a lifetime women have had 13 smear tests, or more recently with changes to the over 50s to 5 yearly screening to 11 tests. You can see if you are in a country where there's annual or biennial screening, that you can have many more smear tests in a lifetime. But with organised population-based screening, we've seen high uptake and dramatic reductions in cervical cancer. When we look at cervical cancer, this is from the UK, the most recent data. Cervical cancer itself is a disease of young women with the median age of presentation at 34. When you look at the pink line, which is the age-specific incidence, there's a second peak in older women. And that used to be a much larger peak because those were the women that were unscreened. But you can see there remains a persistent risk out to old age, which doesn't diminish and doesn't go away even once we're women in their 80s and into their 90s. And having said that, this is looking at the age standardized rates by age. The increases we've been seeing in cervical cancer have been related to younger women, which we'll hope will reduce with the HPV immunization. And when we look at older women, there's been a stabilization in those rates of cancer and even a suggestion of some increase in more recent years in older women. Pre-cancer itself, which is what cervical screening is about, is detecting disease before it becomes a cancer. And one of our leading gynecologists in Scotland, Ian Duncan, used to always say the day you want to have your smear test is the day before you get cancer. And there's that huge peak in the 25 to 29-year-olds in the UK data because that's the age at which we start cervical screening. And it disappears after 64 because that's the age at which we stop screening, although there's some incidental pickups there. But so you'll see quite a different pattern of disease because of it's dictated by the screening program and when you screen and who you screen. So here again, if the high rates of precancer, cervical carcinoma in situ or CIN3 are very high in the 25 to 34-year-olds. When it's picked up, we're already seeing this reduction, which will continue to fall, but really kind of stable rates when we look at the higher age groups. And the cytology itself is not a good test for older women. So this is a smear test taken from young women. We can see clearly the normal cells in the right-hand corner where there's a lot of cytoplasm. These are from superficial cells with small nuclei, and we can see those dark staining atypical cells very clearly. Cervical screening becomes difficult after the menopause because of the lack of estrogen. So you can see a lot of inflammatory cells because of atrophic vaginitis and cervicitis. We can see more parabasal cells where we've got larger nuclei and that increased nuclear to cytoplasmic ratio. So it can be challenging for the cytologist to interpret cytology. And it can certainly be challenging for women to have smears taken as they get older, not just from atrophic cervicitis and vaginitis, but getting women positioned in couches for smear taking and for colposcopy examinations as well. So HPV itself was only identified really as an essential factor in developing cervical cancer in 1976, although the Italian epidemiologist Rigoni Stern reported the fact that there was an infectious cause and that married women were a high risk group for cervical abnormalities back in 1842. And although we'd known for many years that there was an infectious cause of cancer, it was only that first identified that the HPV virus under electron microscopy in 1942, and then it's linked to cervical cancer in 1976. But thereafter, it moved quite quickly, both in using HPV as a test, so testing for success after treatment that we call a test of cure, for triage in women with cytological abnormalities into higher and lower risk groups in the UK from 2011. And now most countries moving to primary HPV screening as a way of improving that screening test. And of course, HPV vaccination, which first came in Australia in 2006 and has gradually been adopted and is highlighted by WHO as one of the key pillars of cervical cancer prevention. But HPV vaccination is a prophylactic vaccine. It's best given to people before they're exposed to the HPV virus because it's a prophylactic vaccine. So we're talking about decades before we feel the full benefit of HPV vaccination. And we're still working with a largely unvaccinated population. The benefit of HPV testing for cervical screening is that it gets rid of the subjective nature of cervical cytology, and the benefit is having a negative HPV test. So we know that if you're HPV negative, you're at the same risk of going on to develop a CIN 7 years after a negative test as you would 3 years after a negative cytology test, so you can extend the intervals for screening. But that leaves us with the difficulty of what we do with older women who are persistently HPV. So if you're working where you have a program where you exit women at an upper age limit, what do you do with the women who are persistently HPV positive? We don't have a treatment for HPV itself. And that infection probably represents an infection they picked up in their teens and 20s, and they've had persistently throughout that time. And many women will have no clinical effect from that HPV infection, but some will remain at risk, because I've already shown you that older women do still develop cervical cancer. The other issue is that the young women that we're vaccinating, that we're picking up, often have disease related to HPV 16 and 18, and they're the most oncogenic. So they're the most likely to persist and to result in cancer, and over a relatively short time period. So these are the women getting cancers in their 30s, are the women often with HPV 16 and HPV 18. When we look at cervical cancers that older women are developing, they're less likely to be attributed to HPV 16 and 18. So it's the ones with a lower oncogenic risk, but the women have had these persistent infections for a long time. So now we're trying to detect disease in women where there's difficulties in having a test taken. There's difficulty interpreting cervical cytology in a cytology-based system, but also that they may well now have an infection which they might have had from decades, but it's one of the non-vaccine types. And a lot of the HPV tests might use selected genotyping to pick up those very high-risk 16 and 18 infections, or be driven by those more prevalent disease. And therefore, you need a test that's going to detect these women with these rarer high-risk HPV types. So this is HPV infections from Scotland, and this is when we looked at the prevalence of HPV infection prior to our immunisation programme. But pretty much this is a pattern that you'll see in any country in the world, where women in their teens and early 20s have very high rates of HPV infection, and gradually with the time that reduces. One, because your immune system clears the virus, and two, because you're less likely to be developing a new infection. And it's very likely because the transformation zone of the cervix is the area that HPV virus infects, that by the time you're postmenopausal and you have a mature cervix with mature squamous epithelium, your transformation zone will now have retracted into the endocervical canal. You're not at anything like the risk of acquiring new infections, even in new relationships, as you would have been as a teenager. And also your partner is less likely to have an HPV infection itself. So the concern is not so much about acquiring a new HPV infection, it's about having a persistent HPV, which might be of a lesser risk type. So this was the data that was just published last year from the HPV primary screening pilot studies in England, and they are now into the third year of HPV testing, the third screening round, so that's been running since 2006. And of course, a great advantage to postmenopausal women with HPV testing is you're less likely to have an inadequate sample, with higher rates of inadequate samples and having to repeat samples with cytology-based testing. Interestingly, what they found from the pilot sites in England is though you're more likely to have a positive result with HPV testing, the referral numbers to colposcopy were for investigation of an abnormal result were not very different, and the positive predictive value when you come to colposcopy of having high-grade disease was similar. But of course, there is differences once you start to look at by age group. So again, in the UK, we're doing screening up to age 64. So when we look at the 50 to 64-year-olds in that bottom line of this table, the total number of CIN2 pluses is very small compared to women in the 24 to 29. So in the 24 to 29-year-olds, 64 per 100,000 women had a high-grade CIN, but in the 50 to 64-year-olds, 5 per 1,000. And that's not also to say that it's more difficult to detect these lesions, which can be inside the canal. But when we look at the HPV testing at baseline, at 12-month recall and 24-month recall, so in the younger age groups, as you have your HPV tested at 0 months, 12 months and 24 months, if you're HPV positive, you see that HPV positive rate diminishing as women clear their HPV infection. But when you look at the 50 to 64-year-olds, that HPV testing at 12 months and 24 months is pretty much the same. So these women have been persistently HPV positive and not clearing that infection, and that is a challenge. So there's different ways of managing women who are HPV positive. What you would hope is if you're HPV negative, that you could be discharged back to having a smear test done. If you're HPV positive, you want to identify the women who need to come to colposcopy and have treatment done. And what you don't want to do is leave women in limbo, not really knowing what the significance of that result is. Because that is the concern around HPV testing. And this study was done again in England in relation to the pilot programme. And it was a survey of 1,000 women taking part in HPV primary screening. So this wasn't how they would feel. It was women who actually got that HPV positive result. And for postmenopausal women, there was a lot of concerns about that emotional response, about understanding HPV because they hadn't heard of it before. It was more common for women who were younger to have knowledge because they'd had the vaccine. Concerns about their partner and whether their partner had been unfaithful to them, and what were the future implications given that they weren't clearing that HPV infection at anything like the rates that younger women were done. So there were concerns very specific to postmenopausal women. So the women with the abnormal test will come to colposcopy to have their cervix examined. Here's our normal premenopausal cervix. We can see the squamocolumnar junction very clearly. We can see the cervix very clearly, and a very normal, healthy looking cervix. Postmenopausal women, much more challenging. We might not be able to see the squamocolumnar junction. This patient's got a number of Nabothian follicles. She's Paris. The cervix is much flatter and larger, so it becomes much more challenging now for the colposcopist and more difficult for the patient. And I always think every picture tells a story. So this is a normal cervix, but it's like when you examine somebody's abdomen or anything, age and life experiences will have their effect. So she's got Nabothian follicles. That red patch down at 6 o'clock, that's just the trauma putting in the speculum. Someone's caused a subepithelia petechiae performing the examination. And I don't know how good you are at colposcopy. I can't see where the cervical os is there. It's very atrophic and narrowed. So to perform colposcopy, that's what we call inadequate. We can't do an adequate examination with our cervix like that. Or here's a patient again where there's no columnar epithelium to be seen. We can't do an adequate examination. So part of the interest is in self-sampling now that we're doing HPV testing for screening. I think with COVID, the general public are much more aware of self-sampling and taking that sample and sending it off themselves. There is a number of different studies looking at the uptake of self-sampling, and it can increase by about 10% if you use self-sampling. The difficulty is once you self-sample for HPV is what do you then use as a triage test that might be useful. So a lot of the work has looked at identifying HPV 16 and 18 specifically as a genotype, which I've said is useful in the under 30-year-olds and in younger women, but it's probably not so useful in older women where it's non-16, 18 types. And so we don't know how useful that will be in older types. And we maybe need to be looking at 31, 33, 45, 52, something like that. We can use different molecular staining to try and pick up signs of disease, which are more objective than cytology. But again, it does mean picking up adequate cytology to identify. And again, that has not been validated in older women where cytology can be difficult. So really, once we're doing HPV screening, what we really need are some additional testing to put in where you can really tease out who are the women who've got an abnormality and we need to bring them in and do treatment, and who are the women who are low risk. And what we don't want to be doing is generating a lot of women where there's uncertainty and you can't identify what risk they are. So certainly in the UK, the issues that we're looking at is, can we extend screening intervals further? What do we do with HPV positive women beyond the age of 65? Is self-sampling going to be the answer? And is that going to be useful in older women? And how do we deal with these women coming to colposcopy and the challenges of the colposcopy workload? So probably more questions than answers there. And then finally, if you're in a part of the world where you're still going to be up this evening, we're holding in celebration of International Women's Day a seminar from the Aberdeen Centre for Women's Health Research, where I work this evening, and you're very welcome to join us. So thank you very much, and I'll be delighted in the Q&A session to take any questions on this topic.
Well, thank you very much, Professor Cruickshank, for a very interesting presentation. I'm wondering if Dr. Nwokolo's camera is, there she is. Nneka, I've already introduced you, and I appreciate your being here to share your knowledge on sexually transmitted diseases in older women. If you didn't hear, Dr. Cruickshank is going to handle the Q&A after you're done. But thank you again for being here, and we look forward to your presentation. Welcome.
Thank you. Thanks very much. So thanks very much for inviting me to speak to you today about STIs in older women. As mentioned, I work for ViiV Healthcare, but I also continue to do an HIV clinic at Chelsea and Westminster Hospital, in which I see women living with HIV who are experiencing menopause. So it's interesting that Dr. Cruickshank also showed a slide from the Daily Mail, and so I have my own Daily Mail slide. And many of you will have seen headlines like this. And although younger people continue to account for the majority of STI diagnoses, we are seeing an increase in rates of STIs among people over the age of 40, particularly in high-income countries in recent years. And in England, approximately 7% of new STI diagnoses in 2018 were among individuals aged 45 to 64 years old. And this Forbes article from 2020 reported historic high rates of STIs in older Americans, and there have been similar headlines in Australia, Canada, and European countries. However, these reports aren't new, and you can see from this headline in The Independent, similar discussions were being had in 2010. So although I think the issue of STIs in older women has been, or in older people has been brought to the fore more recently, actually rates of STIs have been increasing for several years. This is a slide from Public Health England, and it shows rates of new STI diagnoses by gender and age group in 2020. And as you might expect, young adults have the highest rates of new STIs. And in men, these are highest in 20 to 29-year-olds. And in women, rates are highest in 15 to 24-year-olds. And this is because women generally tend to have older male partners. Rates are higher in older men than in older women. And I'll say something about this a little bit later. And although the overall rates and numbers of STIs in women over the age of 45, which I've circled in pink, are low, this hides the fact that these have been increasing year on year. Here you can see new STI diagnoses in women aged 45 to 65 plus in England between 2016 and 2019. And new diagnoses of chlamydia, gonorrhea, and syphilis increased significantly in England between these years. And there was overall an 11.2% increase in total new STI diagnoses over this period. You can see that there was not a significant increase in new diagnoses of herpes or genital warts, so HPV infection. And this is probably because immunity from lifetime exposure, this is probably because of immunity from lifetime exposure to these viral infections. And another infection that is increasingly being seen in older individuals is HIV, with 1 in 6 new infections in the United States and in Europe occurring in over 50-year-olds. In Europe, the annual average age change in new HIV diagnoses among over 50-year-olds was 2.1% for men and 1.3% for women. And this is important because over 50-year-olds are more likely to be diagnosed late with their HIV disease. And I'll discuss this in some more detail in the next few slides. Of people diagnosed with HIV in England in 2020, women and people aged 50 and over were more likely to be diagnosed with a CD4 count of less than 350 cells per microliter, which is a definition of late disease. And you can see this highlighted by the pink circles. And people diagnosed late are at increased risk of developing AIDS-defining illnesses, and they continue to have a more than 7-fold increased risk of death in the year following their diagnosis. In 2020, the 1-year mortality was 31 per 1,000 individuals diagnosed late, compared to 4 per 1,000 individuals diagnosed promptly. And the impact of late HIV diagnosis on 1-year mortality is particularly marked in people over the age of 65. At 59 per 1,000, that is 2 deaths in every 34 people diagnosed late in 2020. So this is a significant risk of mortality. As noted before, in general, STIs are more likely to occur in younger people than older people, or certainly younger women than older women. But 2 conditions are more prevalent in older women than younger women. And these are trichomoniasis and bacterial vaginosis. Trichomoniasis or Trichomonas vaginalis infection is the commonest non-viral STI worldwide, although the prevalence varies from location to location. So it varies, the rates in resource-limited settings are between 3.2 and 52%, and in the United States between 7.6 and 12.6% on average, but rates may be higher in other settings. So for example, rates in the United States in incarcerated women may be as high as 50 to 60% in the United States. In the UK, however, TB is an uncommon infection and appears to be clustered particularly in individuals of Caribbean origin. But because few TB surveillance systems exist, it's not routinely screened for and so is often overlooked. And it's often been described as a neglected STI. Trichomonas, as I'm sure you're aware, is associated with infertility, with perinatal morbidity, with a risk of cervical neoplasia, and with pelvic inflammatory disease. But importantly, it's also associated with an increased risk of HIV acquisition. The prevalence of TB increases with age and peaks at about 40 to 51 years of age. And this infection may persist for many years, and so it's not always a marker of recent sexual acquisition. The menopause transition is associated with progressive and persistent alterations of the vaginal microflora, in contrast to premenopausal women, in whom these changes often revert spontaneously in up to 50% of people. And reduced estrogen production increases the vaginal pH and results in the depletion of lactobacilli species. And so this results in increased colonization with bacterial vaginosis organisms such as Gardnerella, Prevotella, and Streptococcus, among others. And in addition, estrogen deficiency associated vaginal atrophy results in increased susceptibility to microtrauma and potentially an increased risk in acquisition of HIV and STIs. Estrogen replacement, however, has been associated with the restoration of the vaginal microflora to a lactobacillus dominant state. And so this is something that may be important to bear in mind when thinking about managing women who are sexually active, for example, and who have bacterial vaginosis. So what is the reason for this increase in STIs? It's multifactorial, as is the case, I think, with many disease conditions. Older people nowadays are much more physically active than they were perhaps 30, 40 years ago, and so are also more likely to be sexually active. The increasing use of erectile dysfunction drugs means that more men are sexually active into older age. High rates of midlife divorce and widowhood also mean increased partner change. And the phenomenon of online dating is thought also to have an impact, because women are less likely to know the background and sexual history of their partners as they might have done if they had met face to face and spent some time together before they became sexually active. There's also low risk perception of low STI risk perception and low condom use in older women, many of whom have come out of long-term relationships in which they didn't need to use condoms. And because they no longer need to prevent pregnancy, there's no sort of thought about other conditions that might need to be prevented, such as STIs. And there's also evidence to suggest that older women, or older people actually, not just women, tend to prioritize intimacy over the risk of STIs in new relationships. And we know that the majority of older people have not had any formal safe sex education, and so are not necessarily aware either of the risks of STIs or of how to prevent them. The other issue is that no one talks about STIs, and no one talks about sex, particularly in people of the older generation. There is embarrassment about discussing sex and STIs generally, and this applies both to clinicians and to patients. And this is, as I say, more so the case with older people. And older people don't ask to be tested. But aside from that, doctors don't offer testing. And often this is because doctors are afraid, or clinicians generally are afraid to cause embarrassment and don't have the words to use. And I'm sure that I'm probably not speaking to an audience for whom this is an issue, but many doctors are not comfortable talking about sexual activity outside of the context, for example, of pregnancy and childbirth. And as with HIV, there is a risk of late diagnosis, so this refers to STIs, and with this, the risk of onward transmission and complications if these infections remain untreated. And HIV is of particular concern because symptoms such as fatigue, weakness, and memory loss may be mistaken for signs of aging or other conditions, and so people don't think about HIV until a person develops sort of cardinal symptoms and signs of HIV, at which point a test is done, and by that time their disease is late. So why is this a particular issue for older women? Well, I've discussed the issue of lack of awareness and low condom use and so on, but there are also biological reasons for an increased risk of STIs in older women. The mucosal disruption and alterations in the vaginal flora that occur as a consequence of estrogen loss have been associated with an increased risk of HIV acquisition. Many STIs, such as chlamydia, gonorrhea, and syphilis, may be asymptomatic, and rates of STIs in male partners of a similar age are higher than in women. And so an older woman might be more likely to have a new sexual partner who already has acquired an STI because they have had sex with a younger woman where the risk of STIs is higher. There is a tendency to characterize one's exposure to STI risk in relation to people's former relationship status rather than their current circumstances. So if in their previous relationship there were never any STIs, there was never an issue about STIs, people often don't think about their current relationship as being different. And also sexual health campaigns and services are not geared towards people of the older age group. And that potentially leaves a perception that older people are not at risk of STIs. So what potentially can be done to address this? And I think, as with all sensitive subjects, it's important to create an environment that allows people to confide in clinicians and to normalize discussions about sex with older people. And I think if clinicians are not embarrassed to ask questions or to raise the subject, patients are less likely to be embarrassed. So if it's just seen as normal when a clinician starts to talk about it, then I think patients are likely to be more comfortable responding. It's important to ensure that genital health is optimized. The use of HRT, whether that's systemic HRT or vaginal estrogen, has been shown to normalize the vaginal flora and so provide protection against STIs and HIV, and giving people advice on lubricants and moisturizers. If there is a risk, so raising awareness of the possibility of HIV, there are lots of reports that women travel abroad and may seek sexual partners abroad. And if these partners live in parts of the world where the prevalence of HIV is high, then the risk of HIV is high. So advising about pre-exposure and post-exposure prophylaxis, as well as with condom use, is really important, as well as just talking about the overall risk of STIs. Professor Cruickshank talked about self-sampling, and this is well known and well established in sexual health. Vulvovaginal swabs for STIs and finger prick samples for HIV and syphilis testing is now something that is done routinely. The pandemic has really entrenched these. So having people take their own swabs, take their own blood tests, and then send them to laboratories in the post, then means that people don't have to suffer the indignity, in inverted commas, of having an examination. This is really only the case for people who are asymptomatic. Certainly, if you're symptomatic, then it's very important to be examined. But for asymptomatic individuals, self-sampling and online postal testing is really useful. And so I talked a little bit about public campaigns, and there are now some public campaigns that are trying to raise awareness of STIs and the importance of being safe and having STI screening. And on this slide, you can see some examples of that. And so I'll leave you with that thought, and I'd like to say thank you very much for your time.
Thanks very much. So we're going to move on to the Q&A session. So if you can put any questions that you have into the Q&A boxes rather than into the chat boxes, and we'll try and answer your questions here. So I see the first question there is to myself, and it's about the acquisition of HPV in younger women rather than older women, and changes that make this more or less likely. So there's very good data from across the world showing that high rates of HPV are in younger women. So about 30% of young women would be and men would be positive at any one point, whereas it might be more like 5% in postmenopausal women. So one reason for that is just that you're more likely to be sexually active and have a number of partners. And certainly I was interested in what you were saying, Nneka, because one of the risk factors for teenage girls is if you have sex with older men, whereas you're much safer if you're 15 and you have sex with your 15-year-old boyfriend. The other thing is that HPV selectively has to get in through micro traumas and micro abrasions. So it's not like postmenopausal women actually having tearing and splitting and macroscopic trauma, these micro traumas, and they infect the basal cells at the transformation zone of the cervix. So when women are young in their teens and 20s and they have high estrogen levels, they often have a cervical ectopy, and that area is out on the surface of the cervix, so amenable to HPV infection. Whereas with low estrogen levels, even if women are using topical estrogens, there's shrinkage of the cervix and reduction in stroma, and the transformation zone of the cervix where HPV specifically infects is drawn up into the endocervical canal. So even if women are in new relationships, it's much harder for them to acquire an HPV infection. And so even if they have got new partners in mid or older life, or if they're using HRT, it's still not the same as that teenage cervix and the susceptibility to HPV. So I'm hoping that has answered your question. And then your next question is about HPV vaccination. So from a public health point of view, you're going to get best use of vaccinating young people before they're exposed to HPV. It's a prophylactic vaccine, so it's too late once you've already acquired an HPV infection. And so that's why the emphasis has been on vaccinating people under the age of 15 to try and vaccinate them before they're exposed to HPV. And it's interesting because that age was picked because that's what was acceptable to parents, but you could vaccinate much younger. It was also picked because we didn't know how long the vaccine would be protective for. So there was a concern if you vaccinated too young, you wouldn't protect. For older women, there has been trialed like the Vivian trial vaccinating over 26-year-olds, but it's showing you disease is much rarer in older women. So, and taking longer to develop with these non-16, 18 types. So actually they had to keep extending the trials because there wasn't enough events to measure. So from a public health point of view, it just doesn't make sense. And as we know, vaccines are there to protect the population, not the individual. So again, it doesn't make sense to vaccinate individual women who are requesting the vaccine. So I don't see the advantage there. So yes, people will be getting divorced and having new relationships, but there's no evidence to show that vaccination is of use. And there's a lot of interest in therapeutic vaccines, and there's a number going through clinical trials, but we don't currently have any therapeutic vaccines to clear HPV infections. Okay, so Nneka, can I put this question to you from Teaba? Is there differences in symptoms between younger and older women with STIs?
Thank you. That's a good question. So in general, no. The symptoms of chlamydia and gonorrhea, for example, and of syphilis are the same regardless of age. But women who have vulvovaginal atrophy and have vaginal discharge and vaginal irritation due to vulvovaginal atrophy may have symptoms that mimic the symptoms of an STI or that mask the symptoms of an STI. So if a woman has had atrophic vaginitis and has had symptoms of that and then goes on and hasn't had it treated and then goes on to acquire an STI, if she has symptoms of that STI, she might not recognize that she has an STI, because these symptoms are occurring on a background of vaginal discharge that is already pre-existing. And so it's really important for women to be aware of the fact that if they have had sex without a condom with a new partner, that there is a risk of an STI, and to test routinely for STIs following sexual activity with a new partner if it's been unprotected.
So Nneka, if I can put the next question to you as well, should we ask every perimenopausal woman about the possibility of STI?
I think we should ask every woman about the possibility of an STI. So I think we should ask all women about their sexual activity. And I know that this may be an uncomfortable subject for many people, but women are having sex. And many women don't realize that they might be at risk of an STI. And I think if we normalize conversations about sexual activity, then people will answer them. And I think many people will be thankful for being asked, particularly if an issue that they've never thought about has kind of come into their consciousness. So saying, are you sexually active? I'm asking you this question because we know that rates of STIs are going up, and I just want to be sure that you're protecting yourself and that you know where your risks are. I don't know of any circumstances in which that would be received badly if it's asked in a sort of sympathetic way, a sympathetic and non-judgmental way.
I was quite interested in that one because we get referred women who've got symptoms suspicious of cervical cancer, such as post-coital bleeding. And actually, it's much more likely to be a chlamydia infection. Yeah. And it's amazing that people forget that women of all ages have sex. So that's one that we're used to saying, look, just routinely we check for chlamydia with this symptom. Yeah. So the next question, I think, both of us could maybe give a different perspective on answering it. It says, do you see postmenopausal women with vaginal varicosities? And it says, could this be related to an STI or pre-malignant issue? So if I ask you, Nneka, first of all, about vaginal varicosities.
Vaginal varicosities are common. They're more common as people get older, but as far as I am aware, there is no relationship to underlying pathology in terms of infection. I think they're just part of getting older as tissues change and so on. But I'll be interested in what you have to say, Professor Cruickshank.
Yeah, I mean, we're the same, that we get sent women with varicosities because the expectation is you see them in pregnancy, but we see them in women of all ages, but there's no pre-malignant or suspicious feature to it, and often they'll have other varicosities as well. So the next question is to you, Nneka. Can you tell us anything about laser therapy and changes in vaginal tissue lowering the risk of vaginal vaginosis?
So I'm not aware of the use of laser therapy as a treatment for bacterial vaginosis, if that's what you're referring to. But thinking about it, I can't see really how laser therapy would be helpful, in that bacterial vaginosis is really a condition in which the balance of the normal bacteria has been changed. And so if you do laser therapy, but you don't restore the vaginal pH back to normal, and you don't restore the vaginal flora back to normal, I feel that the condition will persist. So I'm not aware of a role for laser therapy in the treatment of bacterial vaginosis.
I mean, if it's in relation to atrophic vaginitis, I know that fractionated lasers being promoted for that, but certainly from my perspective in the vulval clinic, we would say that patients having that should be in a clinical trial, because we don't have evidence about any medium or long-term adverse effects from fractionated vaginal laser. So there's certainly, in Scotland, there's concerns that it could be the next vaginal mesh if we start using it without really properly evaluating it in a clinical trial context. So I'm hoping that's answered the question and that we've got that one right about what conditions we're talking about there. So the next question about non-hormonal therapeutic treatments for HPV, and I suppose that's a difficulty is we don't have a treatment for HPV, and I can tell you from seeing older women in my colposcopy clinic, I wish there was a treatment. I've come from this meeting straight from my colposcopy MDT, and a lot of the cases being put onto the MDT are women who are now over 50 with persistent HPV or low-grade cytology. And I was interested in what you were saying, Nneka, about the microbiome, because certainly there's evidence to show that your microbiome can affect the persistence of HPV. And there's a feeling that a good microbiome is a good thing to have in preventing HPV, and that pro or prebiotics might be useful, but nobody knows which one are useful. Is it oral? Is it intravaginal? There's some evidence to suggest that it's sustained use. It's not just something that you would use for a few days or a few weeks, but actually we don't yet have the evidence on what that non-hormonal treatment would be. It probably is around some way of modulating the microbiome, but we just don't have that at the moment. So there are a lot of companies looking at non-hormonal therapies, and currently we're kind of waiting for stronger evidence on what that might be.
Yeah.
So vaccination of boys. So this really is a global issue, because currently there is a global shortage of HPV vaccines, and that's not just due to disruption from COVID and implementing a vaccine program. That there was a shortage before COVID, and it will take a few years to actually produce enough vaccine to meet the global demand. So one of the concerns is the huge burden of cervical cancer is in low-income countries, but high-income countries, by introducing gender-neutral vaccination, are actually taking away some of the supply that could be used in low and medium income countries. So there are concerns around that, but certainly if you do not have high uptake of vaccine in your girls, it certainly makes a more robust program. And you're absolutely right, because from the point of view of reducing transmission of the vaccine, as well as preventing disease in MSM, there's a huge advantage to having gender neutral vaccination, and we've had that in the UK since 2019, as well as offering HPV vaccine to MSM up to the age of 45. So in an ideal world, there would be enough vaccine for everybody, and if you make it gender neutral, there's advantages to everybody from doing that. Oh, next question. Hi, Susie. It's nice to get a question for you. So I have to say that the issue of women who have HPV over the age of 50, when I talk to my Finnish colleagues, they find this hysterical about why would there be an issue? Do these people saying they've not had sex? We always go back to, just about all of us have had chicken pox. And we find it a bit odd if you say you're an adult and you never got chicken pox, that they're a bit of the kind of odd ones out. It's exactly the same with HPV. You pick it up when you're younger. And just like chicken pox, some people will get shingles, but not everyone. Some people might go on to have abnormalities. But we would say that, nobody knows who got the infection first. If it was your partner, chances are it's something you picked up in your teens and your 20s. And we really try to take away that there's any issue or that it would be a recent infection. But that is definitely what came out from that BMJ paper, where they were looking at women in the UK, that this concern. Can booster vaccination for HPV infants be of any use? So there's been no specific trials at looking at vaccinating older people, although there was the trials such as the one I mentioned, the Vivian trial, did look at over 26-year-olds. It included women who had previous HPV infections, but the any benefit is minimal. There's more interest now in vaccinating women who've been treated for disease. And again, we're waiting for the results from those clinical trials. So next questions for you, Nneka. Postmenopausal woman becomes sexually active with new partners. When would you suspect she's got an HIV infection if symptoms are similar to menopausal symptoms?
Thanks for that question. So I think there are two issues. The first is if she starts to have menopausal symptoms soon after she, well, I mean, it wouldn't be soon because you don't start to develop symptoms of HIV. I mean, you can develop symptoms of primary, so acute HIV infection very soon after you've caught it. And those generally settle down without treatment, and then you go through a long phase of no symptoms at all until you develop advanced disease, and that may be many years. But anybody who is sexually active who develops new symptoms, you know, so who develops a fever, sweats, fatigue, and so on, if they're sexually active, should be encouraged to have an HIV test. And sexually active people should actually have STI screening, including HIV testing, fairly regularly. You know, men who have sex with men are recommended to have STI screening and HIV testing every 3 months if they're very sexually active. And in the general population, people should at least have an HIV and STI screen once a year, at least. But if they have recent sexual activity, they should have STI screening. So if you have a sort of one-off partner, then the recommendation is that you should have a sexual health screen, you know, about 3 months after the exposure, just to be sure that you don't have HIV or syphilis. Tests for STIs like gonorrhea and chlamydia, if you have them, will be positive in about 2 weeks, whether you have symptoms or not. So timing your STI screens according to the particular infection you're trying to identify is important. But I think the recommendation is that people who are sexually active should regularly have STI screens to make sure that they don't have anything, because many infections don't have symptoms.
Great, thanks very much for that. That was really clear. So that there's no recommendation about vaccinating male partners if women have got an HPV infection. There's no evidence to show that wearing a condom reduces any transmission. So we know that HPV is also implicated in anal cancer and precancer of the anus, and yet many women who have anal cancer report that they haven't had anal sex, and it's just that HPV is just kind of such a ubiquitous infection. It's likened to if you spill glitter and you get bits everywhere. So there's no evidence about vaccination or condoms to prevent transmission, and also men don't pick it up in the same way as women, again because of the susceptibility of the transformation zone of the cervix. So Karen, and one of someone earlier in the audience had asked about genotyping, if there's an age limit to that. So genotyping is often used as one of the triage tests with what we'll call a consensus test. Is that first test where it's just positive or negative for high risk types. And the most of the screening population will be in kind of younger women in the kind of 30 to 50 age group. So we don't have evidence on how long HPV genotyping has been done. It's been used in epidemiological studies to look at what HPV types they are, but not in a clinical trial to see how effective it is as a test. And that's because these other genotypes are so rare. So the genotyping works well for 16 and 18 because of that short natural history and how common it is. But I think there will be increasing interest in looking at postmenopausal women and how best when that is the burden of disease. So I think that kind of information will come out. It's a great question to ask. So Nneka, if I can ask you to answer the next question. Should menopausal women be offered routinely GP practice information on the change to the vaginal flora, STI, and a bit of sex education?
I think that I mean, I think the short answer is yes, in the context of menopausal women being asked about sexual activity in the same way that younger women may be asked about sexual activity, because women of all ages have sex. And if we get into the habit of asking menopausal women, of asking all women about sexual activity, when you speak to menopausal women, that gives you the opportunity to speak to them about the particular increased risk that they might have because of the changes in vaginal flora, because of the microtraumas that may potentiate the risk of HIV and STI acquisition. I mean, I personally think that every opportunity should be taken to speak to people about sexual activity and the risks associated with sexual activity, to help people do the best they can to protect themselves. So thanks for that question. It's a really good one.
It is good. It shows me how our worlds intersect here, because I feel as well with older women they could do with sex education, and they've definitely missed out on a lot of information that younger women are aware of, and how useful that would be. So another question to you, Nneka, from Susie. Is there a difference in test performance of bacterial STI tests in menopausal women with GSM compared to premenopausal women? And is there a preferred sample site in women who have got atrophy?
So as far as I know, there is no difference in test performance, and the tests that we do for bacterial STIs are now nucleic acid tests, so PCR tests. So they will pick up genetic material of the various infections, so chlamydia, gonorrhea, trichomonas, and so you wouldn't expect there to be a difference in performance, because you're not relying on pickup of cells, for example. So to my knowledge, there is no difference. And we know that the sensitivity of self-taken vulvovaginal swabs is similar to that of clinician-taken swabs. You don't have to take an endocervical swab, because, I mean, as you said, Maggie, with regard to HPV kind of being like glitter all over the vulva, the same is true for the organisms that cause STIs, chlamydia and gonorrhea. There is DNA from these organisms all over the genitals, and so self-taken vaginal swabs have been shown to perform just as well as cervical samples, and in fact slightly better. So no, there is no preferred sample. The preferred site is the vulvovaginal sample.
Yeah, it's interesting that, because obviously when we're looking at self-sampling for HPV, the interest in Scotland is doing a urine test.
Yes.
So there's a lot of similarities, isn't there, between the two areas?
Yeah. Just to say, so urine testing isn't so good in women with regard to chlamydia and gonorrhea, and that's mainly because there isn't very much material in the urethra, and so vulvovaginal samples do better. But urine testing is very good for men.
So the next question from Rennie is, can a woman take the vaccine without doing the test? And certainly the evidence is there's no need to HPV test before doing vaccination, because even if you have got one of the genotypes, for the bivalent vaccine, it's protecting against 16, 18, 31, 33 and 45, the quadrivalent vaccine 16, 18, and now the non-valent vaccine. So the likelihood is so that there's no advantage in HPV testing beforehand. And then says, what about postcoital trauma at old age? So I don't know, Nneka, if you want to pick up on that one.
I mean, I suppose I would think about this in the context of STI risk acquisition or HIV risk acquisition, because anything that damages the protective epithelium potentially then allows the entry of organisms. And if the epithelium is already compromised by vaginal atrophy, for example, then that may then further increase that risk. And so I think that's one of the reasons that I was talking about the importance of kind of optimizing the vaginal flora in menopausal women who are having sexual activity to minimize the risk of trauma.
We'd probably be seeing the same there, and for sexual activity, and also when we're seeing women and we know we're going to need to examine them at colposcopy, there's a lot of advantages if they've had topical estrogen treatment before. And so I'm wondering if I've come to the end of the questions there.
Looks like it.
Great. So I think that's us come to the end of the Q&A session. That's been very interesting for me, Nneka, hearing your perspective. It's really interesting to hear about that.
Thank you, and hearing from you too, because it's not an area that, I mean, although we treat HPV, wart virus infections with physical warts, we don't have very much to do with the sort of cervical manifestations of HPV and the things that you see. So that was really interesting for me too. Thank you.
Okay, so thanks for everyone who's joined today. And if there's no more questions, then I think we're able to end that session now.
Thanks very much. Thanks, everybody.